Afternoon. This is my third visit to Morocco. I came to Marrakesh in 2010 for the SIU meeting, where we published the SIU guidelines for urethral stricture disease. And I came about in 2021 here. We conducted live surgery workshop with my associate, Dr. Pankaj Joshi. And coming to Marrakesh and Agadir and driving yesterday from Casablanca to Agadir was a fantastic voyage. We enjoyed our travel, and I enjoyed the hospitality and the friendship of the Moroccan people. So I just want to introduce our new hospital that we created. I just want to tell you, this year I'll be turning 72. And when I said that I want to build a new 100-bed hospital, all my schoolmates, my medical college classmates, and then my urology friends laughed at me, saying that rather than retiring to a farmhouse, you're building a new hospital. I said this is for the population who needs it. And in India, there are only 3 100-bed urology hospitals. One is Nadiyad, Dr. Mahesh Desai, and then second is in Hyderabad, Dr. Mallikarjun's hospital, and this is the third one. This is an ultra-modern urology institute, which has about 12 floors. This is on the right, you can see the color difference because the sky is on the left is gray, on the right is blue. So this hospital has 100 beds. It's a very short video. Lord Ganesh, which is a god of wisdom. This is the waiting room. This is a dialysis center. This is going to the intensive care unit. So dialysis beds are 10, intensive care unit beds are 10. And this is Pankaj Joshi taking round here. And this is a private room of the patient. And we have 4 fellows. So these are semi-private rooms. And this is a pathology lab. This is one minute video. And then this is the operation theater. This is the Da Vinci robot. So 105 beds, 11 floors, 5 modular operation theaters, 10-bed ICU, 10-bed dialysis for pathology, blood storage, sonography, CT scan, and urodynamic machine. I just want to talk about when a surgeon designs his hospital, how does he design? So if you look at this is a post-COVID. So we were all worried about transmitted infection. So our floors, the tiles are permanently impregnated with silver ions. Somebody coughs and sneezes, nobody cleans it immediately, it will be auto-sterilized. So this is a special tile. On the right, you can see an electrical switch, and at the bottom, on the corner, it says antibacterial. I touch the switch, and afterwards you touch the same switch, the bacteria are not transferred because this is an antibacterial switch. The bathroom fittings are antibacterial. So have you heard of a hospital where everything, the paint is antibacterial. Everything that where a patient touches is antibacterial. So this is a surgeon designed hospital. We have the latest equipment. We have a Da Vinci robot for last 1 year. 3D laparoscopy we have been doing since 1990. We started laparoscopy in India. Then thulium fiber laser. We have multiple RIRS companies. Mini PCNL. We have Olympus bipolar system. This is the robot. And prostate cancer is not very common in India, so being a reconstructive urology unit, we do a lot of other surgeries. This is our private room here. This is a cafe on the left and a corridor on the right. This operation theater again was manufactured in my city, and the guy who manufactured, his father made the first modular OT 50 years ago for an orthopedic surgeon. So everything is, you can see on the floor, there is no wire there. This is called a media bridge, which I saw it in Hamburg, Germany, and all the wires come from top to the area of interest. On the left, you can see on my desk for the surgeon, and when I switch on the light, you can see that the CTs can be seen on the table itself. There is no CT viewer or X-ray viewer on the wall. And I can draw a picture on the glass there, and I can explain to the patient where is the stricture, how we can deal with it. So this is ICU. So all our patients who are complex, we send to ICU for one night, and then we have 10 dialysis units, and then we are doing kidney transplant also. Publications, one of the largest series of primary PFUI, redo, pediatric and female PFUI. Robotic surgery, we do prostatectomy, partial nephrectomy, cystectomy. We have not done yet, but prostatectomy, partial nephrectomy we do. We are getting a lot of patients of ureteric stricture following high-powered laser, and we are doing buccal mucosa graft, urethroplasty, pyeloplasties. One patient required ileal replacement of ureter, ureterocalicostomy. One lady came from Malaysia. After a car accident, she had a disruption of PUJ due to seat belt. I've seen 2 injuries this year. Then ureteric implant, ureteric fistulae, bladder diverticulectomy, and we do for a large gland, we do what is known as a Madigan prostatectomy. How many of you know what is Madigan prostatectomy? So this is a urethra preserving open prostatectomy. This was described by Madigan. And then you make a transverse incision under the capsule, remove the prostate lobes, urethra is intact. So the patient has no hematuria, and we do this surgery robotically. The catheter can stay only for a short period of time. And we had the first machine to start resume water vapor therapy for BPH, and then this is, everybody has seen resume. Is it available in this country, resume? Yeah? Yeah. So I will tell you a story. My classmate came from one of the cities. He was an anesthetist and took medication for 2 years. His flow rate was 4 ml. We were discussing about him, and then he said, I want to get it done. So Dr. Shreyas under local anesthesia did resume, which took about 5 minutes. And then my friend went away with the catheter for 5 days. The flow rate jumped from 4 ml to 20 ml. And then for a urologist who wants to resect, is unbelievably true that the flow rates can really jump off so much. So thank you very much. So whenever I see a patient at 8 o'clock in the morning, I ask him, have you come for consultation or for surgery? He says, for surgery. I said, don't eat or drink anything, because we have a pathology lab, X-ray chest. Within a distance of this is also bigger. From here to there, he can have all investigations on one floor, under one roof. And then we can do surgery at 1 o'clock, unless he is taking some blood thinners, which we have to stop for a period of time. So I'm very happy that the unit is doing very well, and we have about 8 full-time urologists. And then we have 4 fellows, 2 of GORS who get an American qualification, and 2 are local urologists. And now this year we will be getting 2 DNB students who will be training for general urology. They will get a general, diplomate of national board. So my next talk, this is about introduction, is about pelvic fracture urethral injury. India has 1% vehicles of the world, but our accident rate is 6%. With a population of 1.4 billion, we have one of the largest patient number of pelvic fracture urethral injury. I just want to tell you that the posterior urethroplasty was perfected by my guru, Richard Warwick in England. He's considered father of urethroplasty, and I'm the last practicing urethroplasty surgeon in the world who was trained by Richard Warwick. So this comes directly from the, what you can say, the guru. So I'm going to show you a video about how we do. This is a 22-year-old young man, a road traffic accident, and this is an MRI, but normally we do an RGU MCU. So 3 months later, we do duplex color Doppler of the penile vessels, and this under anesthesia, I'm measuring the length of the bulbar urethra. I pass a dilator, it stops at the site of obliteration, I pull the dilator up and measure the length of the bulbar urethra. So under spinal, I made a perineal incision. This is a Turner-Warwick urethroplasty ring retractor, incising the muscle in the midline. The average operating time is about 60 to 90 minutes, depending upon whether it's a primary or a redo. I apply a mastoid retractor at the bottom, and I'm pushing both corpora on the left side and dissecting the urethra posteriorly between the corpora spongosa and the cavernosa. The distal limit of my dissection is up to the penoscrotal junction. If I go on the penile urethra, then the patient will have a chordee. So I've inserted a finger between the dissected urethra and pull the penis up. It should not go on to the penile portion. Then I apply a Babcock forceps to the ventrally placed spongy tissue, and here I am dissecting and lifting the bulb from the perineal body. At this moment, I insert the left index finger into the rectum, and it gives me tremendous confidence of lifting the bulb from the perineal body, and I'm not going to injure the rectum. So here I pass a dilator, and the dilator stops at the site of obliteration. I rotate the dilator to feel for the tip. If I can feel the tip, my dissection is over. If I cannot feel the tip, I have to go further. Here, after transection, I just want to show you that most people are afraid of this bleeding. These are bulbar arteries. If you compress them for 5 minutes, then the bulbar arteries will go into spasm, and then till that time, I am diverting my attention to the distal end, spatulating the urethra. You can see the bulbar arteries have gone into spasm, and then I can coagulate with unipolar, bipolar, or if you want, you can take a figure of 8 suture here. I pass a dilator from above and try to feel it in the perineum. If I can feel it in the perineum, no problem. But if I can't feel, again, left index finger in the rectum, and we know in which direction to do the dissection. So I'm making a small incision, trying to feel for the tip of the dilator. Then the dilator comes out, and if it is close to the pubic bone, the next step is what we call crural separation. I use a knife to incise between the two cylinders. I call them as two mountains and a valley between the two. And then I don't use a diathermy here because it bunches the tissue. Then I use another mastoid retractor in a upside down position, and I'm dissecting in the midline. The deep dorsal vein of the penis will come to the midline, and then I take it on one side. You can see it has been taken on the patient's left side. Then I make a midline incision onto the periosteum here. I am now passing a small forceps into the posterior urethra. My idea is to incise the posterior urethra in the midline and excise anterolaterally. I bend the tip of the electrode, and this dissection has to be done below the periosteum. If you stay above the periosteum, you are likely to damage the dorsal arteries of the penis lateral to the vein. That's the blood supply to the glans, and the patient may have a risk of developing bulbar urethral necrosis. So, two dissection below the periosteum. Then we have three types of gouge, 5, 10 and 15. I use a 10 millimeter gouge and I'm making inferior pubectomy. The pubectomy, a small pubectomy gives me a fantastic exposure of the posterior urethra, and I'm going to excise part of the bony fragment here, the posterior periosteum and the scar. So as I said, here I am excising the scar anterolaterally. Pubectomy should be wide enough to allow my index finger to go, not big enough, not too wide. I am doing little more pubectomy here. %50 of my patients need some kind of pubectomy. I need pubectomy to have access to the posterior urethra, to excise the scar, and my needle holder should rotate so that I can take sutures into the posterior urethra. I'm using a heavy scissor to excise the bony chips that I have created. So usually you come to this part in about 30 minutes from the beginning of the procedure. Now I do an endoscopy from below to make sure that I can see the bladder neck and the veru. Now occasionally we get patients who have been operated elsewhere and the urethra is joined to the bladder and the patient is incontinent. The posterior urethra should be pink, supple, and you can see it is mobile. The scar is white, firm and non-mobile. So I take 6 sutures, and most important is that the knot should be inside. Knot in the lumen versus knot in the tissue. Knot in the lumen causes less fibrosis. Here I am holding the needle end on. I pass it at 1 o'clock and then I don't leave the needle. This is the 2 needle holder technique. With 1 needle holder, you insert the needle inside. Keep it there, don't remove the needle holder, and the second fine needle holder will pick it up. So 11, 1, 3, 9 and 5, 7. 6 sutures. My American colleagues do surgery. I'm doing surgery in a sitting position. They give exaggerated lithotomy position and the surgeon is standing, and then they take about 12 sutures. Here the idea is approximating the 2 mucosas. I'm not trying to create a watertight anastomosis like a radical prostatectomy. Because here, very difficult to do a continuous anastomosis is in radical prostate. So this is the 3 o'clock suture. And I push the needle inside so that it doesn't engage onto the opposite urethral wall. Then a 14 or 16 Foley catheter is inserted. Then the slack on all sutures are taken off. For tying the first knot, the associate pushes the urethra inside, so the knot doesn't fall by itself. And then occasionally, if there is a redo surgery, I will pull the urethra down and suture to the corpora to reduce the tension. And just to show you that occasionally you can pull both corpora down and then suture it to itself by reducing the length of the penis actually, and then the surgery is performed. So average operating time is about 60 minutes. If it's a redo complex, it may take 90 minutes. We leave the catheter for about 4 weeks. So Barbagli did a study for his buccal mucosa urethroplasties. If you do pericatheter urethrogram at the end of 3 weeks, the leak rate is about 5%. But if you do it at the end of 4 weeks, the leak rate goes down to less than 1%. So coming back to now, a few slides about complex urethroplasty. Most books mention the anastomosis as bulboprostatic here. Can you see this? Bulboprostatic. So the injury rarely is at the apex of prostatic urethra in children, and the anastomosis there is bulboprostatic. You can see this is the bladder neck, and you can see the prostatic urethra here. So this is a child. Normally, most common is the site of injury is bulbomembranous, and the anastomosis is bulbomembranous. You can see this is the bladder neck. You can see the membranous urethra here, and this is at the apex of membranous urethra. The disruption takes place. So this is vital importance. I'll discuss about it later. There is many techniques of spatulating the urethras together. Turnavoric used to transect the bulborethra obliquely, so this spatulation of the bulborethra was ventral. And if he's doing transpubic urethroplasty, the spatulation of this urethra abdominally is anteriorly. This is George Webster, natural spatulation of the bulborethra is dorsal, and he used to spatulate the posterior urethra toward the rectum. And this is what we call a technique where dorsal spatulation of the bulborethra, anterior spatulation of the posterior urethra. The spatulation seems to be on both same side. So the longer sides are coming together and the shorter sides are going away. So occasionally you can rotate this urethra 180 degrees. So you can take the longer side to the shorter side and really nothing happens. So I've showed you 4 different techniques of anastomosis, but which is the ideal method which I follow? The dorsal spatulation, which is the natural spatulation of the bulborethra, and no spatulation of membranous urethra, because why should I incise his sphincter? No spatulation. So this is Turnavoric, my guru again, complex PFUI. So he has classified into many, and we added few. Simple is primary, gap, shorter gap, complex is urethral fistula, failed urethroplasty, longer gaps, bladder neck wide open, spongionecrosis of the bulborethra, double transection, abscesses fistulae, and in girls with a urethrovaginal fistula. So this is a boy less than 12 years. You can see this is the superior pubic margin, and the whole posterior urethra is in the abdomen. So what we do is, after transecting the bulbar urethra, I have gone above into the abdomen. I have done posterior pubectomy. The urethra is re-rotated. The anastomosis is done intra-abdominally. And after excision of the scar and of the bone, there is a dead space created. So I wrap omentum around to keep the anastomosis supple. So this is a transpubic approach which I learned from, which was popular by Turnavoric, and I do it occasionally, maybe 4 or 5 times a year. So this is a complex PFUI with a what I call double transection of the bladder neck prostatic urethra and transection of the bulbomembrane junction. This is semen collection inside, nowhere to go. I am going to discuss about with a video tomorrow, so I won't discuss it just now. This is the super complex case. So Mundy in 2010 suggested that 85% patients after anastomotic urethroplasty have a reasonable external sphincter because the injury is bulbomembranous and the membranous urethra is competent. So I'm going to show you video tomorrow. I'm not going to discuss about this now. Then we have a series of young girls, especially after earthquake in Nepal. The girls were sleeping at night and the wall fell on them. So number of girls came with a suprapubic catheter. In a young girl of 7 and 8, I don't want to do any surgery through the vagina here. So this is suprapubic scar. We do an MRI which shows that there could be a urethrovaginal fistula. So we do endoscopy from above and below. And this is abdominal incision, this is a posterior pubectomy, the scar is excised, the 2 ends of the urethra are taken away, and I suture the vaginal fistula here and do anastomotic urethroplasty. And then we published an algorithm regarding how to manage PFUI in girls and women because we have the largest experience in the world. So this patient was presented to me by Guido Barbagli in Italy. You can see the urethra is joined to the bladder. Patient is completely incontinent. So from perineal side, I transected here the urethra, closed this hole, and joined it to the normal site. And the patient is completely dry and passing urine normally. He was completely incontinent before. We get many patients of rectal through fistula, about 15 to 16 patients every year. And you can see the patient has a colostomy, suprapubic catheter. 3 months later, we do anastomotic urethroplasty. I'm going to show you a video of this, how we close it. I have a nice video. This is a perineal abdominal approach, posterior pubectomy and omental wrap. You can see the pubectomy here, posterior pubectomy. I used to do total pubectomy a long time ago using a jiggly saw. And then what happens, if you excise a part of the pubic bone, the exposure is fantastic, but the patient has what we call waddling gait, and then the penis sinks into the central area of depression between the two pubic bones. So we don't do this total pubectomy. I leave a rim of bone here, and this is omental wrap here. We get number of patients of what we call bulbar urethral ischemia. Normal urethra has this bulbar artery, and these are the cavernosal arteries. This is the dorsal artery of the penis, so the blood supply. Once we transect the urethra, this urethra gets its blood supply through the dorsal artery and through the cavernosal artery. If the patient has erectile dysfunction due to vascular injury, how do we do that? We do duplex color Doppler with and without papaverine, and we want to measure the blood supply. If the blood supply is less, that means there could be erectile dysfunction of vascular origin. Now, if the patient is hypospadias, then the connection between glans and urethra is less, then transecting urethra becomes troublesome. So we may do a vessel sparing surgery. But we have about 10 patients coming to us with what we call bulbar urethral necrosis. There are multiple techniques that we follow. On this slide, you can see that this is the bladder neck, prostatic urethra here. Penile urethra, the whole bulbar urethra is missing, and here the whole bulbar urethra is ischemic. Our first choice is, if the patient is not circumcised, is a pedicle puputial tube, outer circumcision incision, inner circumcision incision, and then we deglove the penis twice, and we have this foreskin with his pedicle. We transfer it from the base of the penis to the perineum. We use 3 centimeter wide, 7-8 centimeter this skin flap, turn it into a tube, and then this is the tube, and then we do proximal and distal anastomosis, and this is the pedicle. What are the problems? There are 2 anastomosis, and there is a skin-lined urethra. It forms a little diverticulum, and the patient has what we call post-micturition dribble. Now, we had some patients, young boys, coming with what we call horrific accidents. I remember one boy who had hindquarter amputation, and then he lost his penile urethra, 1 testicle. There's nothing for me to repair. Now, this boy has a suprapubic catheter, and then he wants to walk. Now, the artificial limb will go around the pelvic girdle after hindquarter amputation, and the suprapubic will not allow that. So we use what is known as the urethroplasty. This is described nicely by Tony Mundy in BJUI. So we use colon, and then he is passing urine normally. When he's walking around, you will not believe that he has an artificial limb. So I showed you a video of primary anastomosis, and I discussed with multiple complex urethroplasties. If you have any questions, I'm here to answer. Thank you very much. If there are no questions, I will invite the next person to come in. Thank you.
You have antibacterial floor in your all institute, or
only in on the operated room.
No. The antibacterial floor is throughout the hospital. All the flooring is antibacterial. This is very important. All tile manufacturers make an antibacterial tile. If you have a grandchild or a small boy on the floor, he is eating anything from floor. So bacteria should not go. So all companies manufacture a antibacterial tile. It is permanently impregnated with silver ions. Huh? It will not go by washing. So how do we test it? So you have an ordinary tile and this tile, like a antibiotic culture, you do a culture and there will be no growth around this tile compared to like urine culture and sensitivity report. Similarly, no. So silver ions will prevent bacterial growth. It is inside silver, yeah. Permanently impregnated with silver ions.
Thank you, Professor Kulkarni.
Thank you.
Can I ask a question, please?
Yeah.
Thank you. So, what is the place for the vessel sparing surgery in anastomotic urethroplasty? Because I saw in the video that you have cut the bulbar artery. Is it mandatory? Is it mandatory to cut the bulbar artery? Because the bulbar artery is posterior than membranous urethra, so it can be spared without cutting bulbar artery. And I have done my recent patient with this maneuver. I have preserved bulbar artery and I have gone dorsally and I have cut membranous urethra only without cutting bulbar artery.
So congratulations for sparing the bulbar artery. This is what should be done. For a short gap which is less than 2 centimeters, this is possible. For longer gaps and redo surgery, it's not possible. So, but primarily, what are the indications if the patient has erectile dysfunction? You have done a duplex color Doppler and the blood flow is less. The patient is hypospadias. You don't know hypospadias. The connection between the glans and the urethra is less. So you don't want to transect the bulbar urethra. So whatever you are saying is perfectly justifiable. This was done for the first time by Jerry Jordan and now by our friend from Chile, Reynaldo Gomez. So we also preserve, but not necessary for a long, it's not possible for a longer gap, like 4 centimeter. You can't push the urethra inside for 4 centimeter. 2 is okay, 2 centimeter.
Mr. Kulkarni, I think in case of pelvic fracture, traumatic, you have to transect. You have not to do non-transection urethroplasty. In case of traumatism of urethra injury, it's mandatory to make a transaction.
No, urethral transaction is required, but for a short gap, you can maintain the blood supply to the bulbar urethra. You can transect the urethra going dorsally, but you may not transect the bulbar arteries. That's possible.
So we can do the technique done by Mandy and Andresh, non-transaction urethroplasty in case of...
Correct. Perfect.
Okay.
Perfect.
But it should be rare, because in case of traumatism, we should transact.
For a short gap, it's possible. For a long gap, it's not possible.
Can I ask you something about your technique of inferior pubectomy? How you manage the dorsal vein? Is it possible that you have injured the dorsal vein during the inferior pubectomy? And in case of injury, what's the consequences?
Yeah, so this is very important. Whenever we do preoperative duplex color Doppler, we do Doppler of, this is all books say about the corporal arteries. What we are saying, we also do Doppler of the dorsal arteries of the penis, which are at the base of the penis. Because somebody has done pubectomy and he used diathermy in an inverted U fashion after crural separation. He has coagulated not only the midline vein, but the dorsal arteries of the penis, which is blood supply to the glans. So suppose one side artery is not good, I will dissect more on that side. And suppose the patient has inadequate corporal and dorsal artery blood supply, then there may be a chance that you may have to do penile revascularization before surgery, like taking an inferior epigastric artery on one side and joining it to the penile artery. So this may be a rare indication of penile revascularization before surgery, but usually the dorsal arteries are spared.
I have two questions. Do you use endoscopy from the cystostomy to be better to localize the proximal
Yeah.
part of the urethra
Yeah, yeah.
first? And how to reduce significantly bleeding? Because in young girls, bleeding can be very, very important. It can be very difficult to do all the skits without. Thank you.
Okay. So there are multiple ways of identifying the posterior urethra. I pass a dilator. Advantage is goes distal at the idea is I want to incise the posterior urethra or the membranous urethra at the apex. Okay. I don't want to lose a millimeter of good urethra. So if I pass a dilator, the dilator will go distal to the veru, I can open it. The problem is blind. If I pass a flexible cystoscope, again it will go distal to the veru at the apex, but I don't want to make an incision on the flexiscope to damage it. If I pass a rigid endoscope from above, like a ureteroscope or a cystoscope, it stops just distal to veru and my incision will be too proximal. Okay. Lastly, we have a Jalil Hosseini technique, Hosseini from Iran. What he does, he passes a flexiscope from above and from perineum he passes a needle. The needle may come at 1 o'clock, 2 o'clock, and ultimately it will come into the center, a tiny needle, and then he replaces the needle with the bigger one and he will make an incision. And this is very important to do a proper bulbomembranous anastomosis. I have done urethroplasty for double transection after TURP, after BNI, and the patients are continent.
Mr. Kulkarni, how can you manage a patient who has done anastomotic uretroplasty and he had previously iatrogenic hypospadias for meatal stenosis, and now he's coming for urethral structure? How can you manage him?
With the PFUI,
In his history, you find anastomotic uretroplasty and used hypospadias for meatal stenosis. Because in our context, meatal stenosis was treated by Moroccan surgeon by induced hypospadias.
yeah. So this is a complex case. He already had anastomosis below, then there is a hypospadias created because of the meatotomy, correct? But the dorsal wall is continuous. If I want to do surgery, now once the bulbar arteries are transected, you can retransect them again. But there is a chance that this patient may develop bulbar urethral necrosis. You have to explain to the patient. And if it happens, we will correct it.
If you permit, Mr. Kulkarni, 50% of your patients you use inferior pubectomy. 50%.
Yeah, 50% patient needs some kind of pubectomy.
How-
So
how
if
to-
I'm just teasing you, if you don't have the pubectomy instruments on your table, don't do anastomotic urethroplasty.
Yes.
Huh? Yeah.
I think it's mandatory because I have a problem of a patient. I can't access the posterior urethra because of the pubis. I want to ask you, do you have any predictive factors before going to surgery? This patient, I will do inferior pubectomy, and this patient will not. I will not do. Do you have-
So there is another paper published by Tony Mundy. He says the most challenging part, most unpredictable part of posterior urethroplasty is how difficult it is to identify the posterior urethra, which you cannot judge. But if you do an MRI, and if you have the dye, if you fill the bladder with saline or clamp the suprapubic catheter, the dye will act as a contrast. If the contrast comes below if you have a horizontal line at the inferior pubic margin, if the dye comes below, less chance of pubectomy. If the diastole is above, more chance of pebectomy. This is again a Corretine's, another law called Corretine's law. So gap is 2 centimeter and the bulbourethra is 7 centimeter, then less than 1/3 gapometry. If the gap is 4 and the length of bulbourethra is 7, more than 1/3, higher chance of pebectomy. So two clues.
What do you think about the technique in which the bulbospongious muscle is spared? Is it not difficult to access? It's already the results are excellent about sexual function and erection, and I saw that all times you open the bulbospongious muscle. What do you think about the manner where we don't we spare this muscle?
We spare the
Muscle, bulbospongious muscle. We just recline the muscle without suctioning. In order to access.
It's like the technique you are using, for example, when you're using, you can mucosa for the urethra, you spare the part of the muscle.
Yeah.
All the muscle is spared,
Yeah.
just a clean and
yeah.
To be
Yeah.
for the vascularity, but in my opinion, it's not possible.
No, we go in the midline and open the muscle and go one side dissection. You want to go around, but what you say is true. If it's a short stricture, what my friend here is saying that we can spare the bulbar artery, then it is possible to go on one side and do it, even more beneficial to the patient. But we have not done it. We'll do it once. How many?
Stitch.
Six sutures.
It's not opinion, Webster and Corritem opinion. Four stitch is enough.
So I will ask you simple two important answers to this. How many sutures? I say 6 because when you do open radical prostatectomy, how many sutures you take?
6 or 4.
Open radical.
Upper 6. Yes.
6. When Turnavoric did anastomotic urethroplasty, he put in 6 sutures. So open prostatectomy at the proximal end of membranous urethra, PFU at the distal end of membranous urethra. I said we want to approximate the 2 ends of the urethra. This is not a watertight anastomosis. I tried to do what you call like a radical prostatectomy. Now, then what happens? You're bunching the tissue and it forms a ring. Because if you pull out a little more, a continuous suture, very difficult to have continuous suture deep inside.
It's not caused ischemia or.
I don't know. No, if you pull, then the anastomosis become narrow. So suppose you're doing pyeloplasty. If you use continuous suture and pull, the anastomosis will become narrow.
Is there, Sanjay, some real injury to the sphincter? Some people are having injury to the sphincter you cannot repair. So,
Injury?
yeah, during the transection of the urethra, the sphincter also is.
No, I didn't understand the question.
No, you have a cut of the bulbar in the membranous urethra,
Yeah,
and the sphincter also is damaged.
yeah.
Is there? You came across some cases like this?
No. So the sphincter, if it's a prostatomembranous injury in young children, then the sphincter is gone, but their bladder neck is competent. So majority of the patients have competent bladder neck. What we want to do in 85% patients, we want to keep the external sphincter also functional, so that if required, suppose I do surgery on a 10-year-old boy, later on he may need TURP at the age of 60. He should not become incontinent. So the idea is the membranous urethra. So whenever I get a patient of a young child with fractured pelvis and with 2 failed urethroplasties, with each failure, bulbourethra is lost by about 1 centimeter and the proximal urethra is again lost because I have to keep on incising proximally. So that time the membranous urethra will may be gone in a child or a redo case.
Dr. Kulkarni, what do you think about spatulation of the proximal edge of the urethra? Because it's not because the anastomosis will be more difficult and more complex?
Oh,
Because
no.
it's the deeper point of the urethra and
Membranous urethra should not be saturated. So this is the figure that I showed you. 5 different types of spatulation. No book, no journal, no mention. I am showing you 5 different techniques, and which is the best one?
Yes, what is the best one? You
Best one
spatulate,
is
you spatulate the proximal or
dorsal
not?
spatulation, which is a natural spatulation of the bulbourethra dorsally, and no spatulation of membranous urethra. Because if
yes.
you just imagine,
Yeah.
the bulbourethra comes like this. There's the what you can say, bulb of the urethra, and the urethra makes a turn, and it's an L shape. You understand? So don't spatulate. If you now do transpubic urethroplasty, if you want to go from above abdomen, you can't see the posterior wall, so you have to spatulate anteriorly. If you go abdominally, but perineally there is no problem. I think there is too much discussion. Yeah.
That's
The
okay.
next lecture.
We take an advantage of your presence here.
Huh?
One of the reasons of conserving the continence is that the shape of the sphincter is a horseshoe shape.
Yeah.
So it's dependent on the fibrosis, nucleus fibrosis of the perineum, and it's around the peak of the prostate, the apex of the prostate, and a little bit on the membranous urethra. When there is a cut, it goes up. If you want to keep it, don't have to cut it longitudinally.
So I told you I have done urethroplasty of a 60-year-old who had a TURP. So his bladder neck is gone, but he is continent. I have done it after bladder neck incision. After double transection, I'll show a video tomorrow. So idea is, there is another thing, only God can make sphincters. Okay, so don't disturb patient's sphincter. Thank you. No, I'm feeling awkward saying that I'm encroaching somebody's time.
No, we have to take advantage of your presence because you are away abroad from India. So we have to take advantage of, of your presence here. Have you ever, in case of anterior pubectomy, you didn't have access to your urethra and you have to switch to from above?
Yeah. So I had one patient, I was operating in a conference like this, all top urologists, and they gave me a patient, young boy. If you see the superior pubic margin, the bladder neck is usually there. This boy had what we call pie in the sky. The bladder is in the abdomen and the posterior urethra is completely intra-abdominal. So I transected the bulbourethra. I did not do crural separation, inferior pubectomy, nothing. I took the urethra on the side and went above the pubic bone and joined it to the urethra, to the prostatic urethra, membranous urethra. So this is the suprapubic urethra. And 2 years down the line, the patient is fine. It's not every day that we have to do it, but it's possible. So if there is what we call pie in the sky bladder, if I cannot do anastomosis from below, we will open up from above. Yeah.
You will be bothered by the prostate in case of BPH or something like that, if you wanted to go from above.
Yeah.
And with
But not more than 5 times a year in men. In girls, every time.
Or question? Sorry? Okay, so we'll sign up for a coffee break and then we'll go back.
Thank you very much. Thank you.